We're going to move on to the next speaker, Thérèse van Amelsvoort. I'm going to invite you to come. We have been talking a lot about hospitals, about rehabilitation centers, about diseases, but we haven't really had much attention so far in these conferences for mental health care. And I think I'm very, very happy to introduce Thérèse, who is our only professor in transitions of care in the Netherlands. And she's working in psychiatry. And I'm hoping that you will give us more introduction about this issue.
Thank you, Annelies, for the introduction and for the absolutely fantastic organization. It's the first conference I'm going to where I don't have to think about anything. Everything is organized. And I'm working as a clinical psychiatrist in a youth mental health team. So young people, I treat patients with psychiatric problems around the transitional age. And I'm also a professor of transitional psychiatry in Maastricht. I've been doing that for 11 years now. Before I want to go on, is there anybody here working in psychiatry? Who's working in psychiatry? One person. Okay, well. Okay. There's a lot of similarities in transition in psychiatry compared to in somatic care. But there are also differences. First of all, the prevalence of mental health problems is enormous. So the scale of the mental health problems, and therefore also the organization and the transition and everything that's coming along with it, is huge. And the other thing is that the majority of mental disorders start or emerge for the first time around the transitional age. So in contrast to children who have had a chronic condition starting at a very young age, it's around the transitional age that it's like a traffic jam of psychiatric problems. And the majority of those people don't have help. So the prevalence is high, and the percentage of young people who receive help for that is very small. And then if you look at the economic impact, the burden of mental disorders is also enormous and far larger than the burden of cardiovascular diseases, diabetes, cancer, and chronic respiratory diseases. And these are numbers from the World Economic Forum. So the societal cost, in addition to the personal burden, the societal costs are also enormous. And the majority, well, actually half of European youth, and these are all numbers from the WHO and the OECD, half of the European young people have unmet needs in the domain of mental health. And this has only become worse after the COVID pandemic, the war in Europe, job insecurity, climate anxiety, which is now a theme at any psychiatric conference nowadays. That doesn't help and adds to the burden. And over the next decade, this will only increase. And just around the age of 18 is our system weakest, where it should actually be strongest. If you look at the lifespan of mental disorders, if there's one moment in life that you should organize your care very well, it's around this age. And if your car breaks down, of course, the rescue services are there in 15 minutes or an hour. But if your mind breaks down, and that in our professional terms, it means you become suicidal. That's the crisis we face with, particularly in this age. It takes a year sometimes to receive help. So what we did is we did a qualitative study, and we interviewed several young people and asked them about the barriers they face and the facilitators when they're needing help. And there were some surprising results, some not. First of all, particularly with mental health problems, there's a lot of stigma and shame. It's much easier to ask for help if your leg is broken than if you have suicidal thoughts. And that stigma comes also from the direct environment, often also their own family. So they really, really feel a lot of shame, and the time it takes to ask, to make that first step to look for help is sometimes years. And of course, that's very bad, because the longer you wait, the problems only get worse. Also, they face a lack of understanding from their surrounding, and also at work. It's still very difficult to talk at work. It feels often very unsafe to talk about mental health problems. The other thing is the pathway to the care is unclear. A lot of people don't really know where to start. And I don't know how it is in other countries, but the Dutch are very good at making things as complex as possible. And so it's sometimes they don't know, oh, do I need to go to the GP to get a referral? Oh, didn't know that. You know, things that for us as professionals are very obvious, are not obvious for young people. And also we have a lot of foreign students, and students in this age, they move around the country. So they start in a new place with no network. And so this step to register with a GP again and finding out where to go to, that is already a barrier. Waiting list, of course, they're tremendous in the Netherlands. 6 months to a year is actually the average. And then the cost, and this is something that I hadn't thought about either, because in the Netherlands, when they turn 18, they have to pay their own contribution. So that's a hurdle. And in Rotterdam, actually, a group have looked at it, and they saw that since they increased that amount, because sometimes they increase this amount they have to pay, since that increased, the number of particularly lower income young people dropped out of care, of mental care. And it doesn't, of course, it's not because there were less problems, but just because of the financial hurdles. And the other thing that they struggle with is in the Netherlands, if for example, the parents pay their health insurance, the parents get the bill. And so they didn't want the parents to know that they were looking for help for mental health problems. So that even prevented them, because they didn't want to have that the parents received the bill with, oh, you're looking to mental health care, for mental health care. So these were all things. And the other things is once you're in the system, well, then, at least in the Netherlands, you're going around from one team to the other, and then somebody does an intake, and the other one does something else, and you see several different people. Also, the turnover, there's a shortage of staff, so the turnover of personnel is also enormous, and that doesn't help. They don't want to tell their story every time to a new person. So, enormous amount of barriers that make that a lot of people actually don't get into care. And these are some of the quotes. So, you know, money, a reason. So the things that I said, these are the quotes they made. And it was really quite shocking. So what can we do? Well, this is a slide that we've talked about in the morning. The Dutch kwaliteitsstandaard, Anneloes' amazing work, the NICE guidelines. But in the left, there's the milestone transition study. And that's a study actually, the first large study that actually looks at the transition in Europe across CAMS and AMS, child and adolescent mental health care and adult mental health care. And it was a European-funded study. I had expected that the researchers who are based in Rotterdam would present here their work at a symposium. So I didn't make too many slides because I thought they were going to talk about it. But now I realize that they are not here. So and the results also only came out. There's still a lot of publications in preparation. But overall, they included 763 young people from different countries across Europe, 39 different services. And they were included when they were in care, in CAMS care, around the age of 17. And they followed them up for 2 years. And there was also a cluster randomized controlled trial where one arm received care as usual and another arm received a managed transition with a specially designed instrument called the tram. And what the results basically show is that, first of all, not everybody needs adult care. Like almost half of the people never made a transition to adult care. And that at the end, after 2 years, those that were not in adult mental health care were not doing worse than the ones that did. So the lesson for us child psychiatrists is that really carefully look, not automatically, everybody needs adult mental health care. Sometimes it can be done by a GP or other support, social worker or educational support, other means of care. But those that do need to make the transfer, they are very vulnerable and didn't experience this as a very nice transfer. And we did, in addition, several qualitative studies. And this is the work that we did in Maastricht. And this paper is still under review. And in 4 countries, including the Netherlands, Ireland, UK, and Croatia, youth and parents were interviewed about the transfer to the adult services. And these are things I think you will all recognize from your own hospital, like no involvement of the family, no preparation, abrupt transfer, bad communication, and the things we all know. And in general, the mental health care is behind to what is the development in somatic care. So this is like the first time that in mental health care this kind of study has been undertaken. And also we asked them advice. What would you advise us? And they said, well, yeah, pay attention to it, of course. But also there was unanimous support for design special youth mental health services, because the need for mental health support around this age is so enormous. And it's either designed for kids or for adults, but there's nothing particularly for us. The other thing that we're facing is, and I don't know really how that is in somatic care, but in mental health care, the child and adolescent mental health care uses different diagnostic instrument and outcome skills than the adult, and they're totally not matched. So a lot of young people enter adult mental health care and say, "Oh, I suddenly got a new diagnosis. Oh yeah, wow, fine, you know," and a totally different direction. So that is really confusion and not helping. So also this needs to change. And a couple of years ago, the Australians have really started a reform and revolution in youth mental health reform. They wrote this review about outcome measures in mental health, and there was actually none that particularly was covering the age around the transition age. It was either for children or for adults. So there was, the emphasis was, of course, we need a new instrument that is particularly covering this age group. And the good news is that we got a new, some of the researchers that were part of Milestone got a new grant, and it's called UGEMS, and that has just started last year. And we are actually going to design a new transdiagnostic instrument that is covering that age range. And we're also currently writing an update of that review. So that is work in progress. So besides optimizing the transfer to adult care, a lot of other initiatives that are happening in the Netherlands, which I also initiated myself, is the development of transition teams or youth mental health teams, where you don't have a boundary around the age of 18. And I'm currently working now for almost 10 years in one of those teams in the south of the Netherlands with one of the large mental health care organizations there, Mondriaan. And we just received, like, Top GGZ is like, some special certification that you have, that is your specialty, and you get a different financial reimbursements because it's very complex. And also it's associated with research. So what is good about it is that the team consists of professionals both from the child department and the adult department. So you're working together in a team, and you're sitting at the clinical meetings, and you just learn so much from each other. You realize your own blind spots from your own adult or child background. So that is really, really 1 and 1 is 3. So you bring it together them in one team. There's also a diversity of professional background, and really it uses a more holistic, flexible approach, which is really personalized and paying attention to the young person. So, for example, students, they move around a lot, or suddenly they go 6 months abroad. So you really have to adapt yourself continuously to their lifestyle, basically. And we don't use care pathways. So within the frame of the legislation of the Netherlands and all the rules and regulations that the health insurance companies impose on us, we try to create our own team that is really created together with the young persons themselves. And what you see at this phase of life is that often making a diagnosis is difficult because they present with a lot of symptoms of a lot of different diagnoses. It takes time to really get a final clinical picture. So what we see a lot is suicidality, and that's of course also scary for a lot of people. But this is a lot of young people in this phase of life face existential problems, searching for their identity. There are a lot of things happening. They have to make choices, and it really, really makes that it's can very easily become a crisis. So we see a lot of people that are suddenly go into a crisis, and then the next day it's over again. So as a team, you really need to be that flexible that you can deal with that. And so we try to focus a lot on quality of life and psychosocial functioning. We also see a lot of comorbidity, and that's not only the mental disorders, but also somatic disorders, or traumatic events in the past, or poverty. All these aspects also have an impact on their mental well-being. And finally, another aspect what we are doing to help young people in this transitional age is to improve the pathway to care. Because as I said in the beginning, for young people with mental health problems, it's very difficult to get into care, but also to ask for help because of shame. But also, if the services are really designed by adults for either kids or adults, then young people are not really likely to want to go there. Why would I want your crappy service? No, they don't want that. They want to have their own voice. They want to co-design their services. And this is in Australia about more than 15 years ago. A guy called Pat McGorry, he started this massive reform and in the field of youth mental health. And now that's really gone around the world, and they started the Headspace centers, and these are walk-in, free centers that you see there to the left that look a little bit, cheerful, cozy. And meanwhile, in Australia, there have been more than 150. They have really evaluated themselves several times, and in Europe, there are also several. We in the Netherlands started at Ease. And you don't diagnose there. The people there just listen. And the young people themselves are involved in every stage of the whole process. So what Pat McGorry did is also create a partnership with the World Economic Forum. He presented his work there just before the pandemic. And they made a whole blueprint. So all the gray areas there on the globe are covered as well. So low and middle income countries also, they have the guidelines now. And you see that the countries with orange, they are all part of this international youth mental health movement. And in Europe, these are the kind of walk-in centers that are kind of brothers and sisters of Headspace that are in Europe. And also Headspace Iceland has opened now, and Israel, and the Maison des Adolescents, which is in France, which is actually it's not only for mental health, but also for somatic problems. It's really a walk-in center for adolescents, and they can talk about anything. And they are also now in the French part of Belgium. And in Switzerland, they are building such a center as well. And I want to emphasize that although there are mental health support centers, young people can come with any problem. So if they have financial questions, questions about practical support, but also if they have a stomach ache or if they have somatic problems, they can walk in to talk about anything. And so this is how we have at ease in the Netherlands. It's for young people between 12 and 25. It's anonymous, it's free, they don't need a referral, they don't need to identify themselves. And all we do is listen. The young people, they decide what they want to talk about. It has a preventative effect. We are bridging the waiting list. And the idea is also to keep them out to specialist services. Why refer them to specialist service if it's not needed? So we really try to de-escalate the crisis and mental health, making mental health problems worse. And we improve. We have a positive approach. The people who do the interviews, they are trained in solution-focused talking. And it's really at enhancing the resilience. So this is how it looks like. It looks a little bit like IKEA type, like a living room type atmosphere. And we are also very visible at social media. And at the moment, these are the locations that are open. There are more coming. And we're also working together with Leuven to set up maybe one there. And one of the key innovative things is that talking is done by young people themselves, by peers. It's peer support, trained volunteers, and there's always 2 people that are talking to a young person. And a lot of them are expert by experience, they have lived experience. But there's always a healthcare professional on site that coaches the peers or that can step into the conversation when it's getting really difficult or if there's a dangerous situation. And then on the background, there are psychiatrists on call by telephone just if needed. So it could be scaled up if needed. And after 5 years of experience, we have hardly ever needed to do that. It's really hardly ever necessary. And for the peers, it's also very, very rewarding work to do. The other thing is that we are a multidisciplinary team. So we are from all angles of backgrounds, working in one team together. So within one city or one location, you have an enormous social network together to help find solutions for the problems young people come with. Of course, we also do research. So because we also asked, can we ask you some questions, the young people? And they said, you first need to listen to us, and then maybe you can ask some questions. So then we give them an iPad. That's also how they do it in Australia and in Denmark and in Ireland. And we ask very, very few questions. But we always ask about suicidality. And all the data from all the different cities in the Netherlands come to Maastricht. And so we've now described our working methods. So the first PhD student has finished her PhD, and the second is now starting. And we're now looking actually into the clinical and cost effectiveness of the model. We did a first cost evaluation, and we looked at the quality of life. And we saw that the young people that visit at ease, the majority have no care. So like 75% of the people that visit at ease have no mental health support, and that their quality of life is already significantly lower than their normal peers. And that's because of anxiety and low mood, but also because of not being able to carry out their daily activities, not being able to go to school or to university or to do their activities. And the societal cost for an at-ease person is already €2,000 a year. Whereas for an adult with a psychiatric diagnosis in mental health care, that's 3,000. So this young person already is costing society a lot, whereas they don't receive care yet. So these are some of the characteristics. We've been open now for 5 years, and we've seen almost 1,000 individual youth meanwhile. And we see that the majority are female. This is in line with what you see in mental health care. We see a lot of foreigners, non-Dutch born. Almost 40% of the people visiting. So that also illustrates how they lack support because they are alone, away from the family, don't know the system. But also financially, in a lot of the foreign people we see have a health insurance that doesn't cover mental health. only somatic health. Yeah. And the average age is around 20, depending a little bit on which city in the Netherlands. And a lot of them are studying. Some people are not studying and have no job, so they're really worrying. They have moderate to severe complaints. 1/3 have suicidal thoughts. Also, 1/3 have a parent with mental illness, so have a youth with maybe unsafe or insecure environment. And also 1/3 hasn't been able to really go to school or work or study every day over the 3 months previously. And the illustration on the right side shows that the majority have, after one session, are fine after 1 or 2 sessions. They don't need anything more. So it really relieves them of the acute need to talk to somebody. And only a minority is going to a psychologist afterward that we re-refer. We can help to make the referral. And they're very satisfied, 4.5 out of 5, with the service they receive. Well, about 1/3 comes more often, because in theory they can come as often as they like. They decide themselves. And we see that the scores on the psychological distress significantly decreases after the 2nd and the 3rd visit, and social functioning increases after the 2nd and 3rd visit. So that's very hopeful for us. That, of course, we cannot prove causality, but at least they do better. And that's what counts. And we also interviewed them what they thought about. This is also part of a qualitative study. And they say what they like about it, so that it feels very comfortable, like a living room, no clinical, sterile feeling, and that you can just walk in, that you don't need a referral, and that it's free. Yeah. Well, then we had the pandemic. We had just opened, and then suddenly there was the lockdown. So, and they still needed to talk. So we started with a chat, and actually after the lockdown was over, we kept the chat because we still felt that a lot of young people were too scared to come in person, and the online chat is easier. And what we see, we've seen now, we had almost 5,000 visits now. What we see is that the people are younger. But what we also, in addition to the normal topics about low mood, we see a lot of, we hear a lot of very heavy topics like domestic violence, sexual abuse, and youngsters that are really feeling scared at home and don't dare to talk about their family. They really are feeling trapped. And so this is. So we realize that the need for the chat is still there. So we're continue with that. And so at the times we're open for the walk-in center, we're also open with the chat. So it's the same team doing both the online and walk-in center at the same time. I don't know how much time I have. 5 minutes. Yeah, I have a trailer, but I don't know if it works. Is there internet there? Can I just click on it? I don't know. Anyway, you will receive it. You can look at home. There's a trailer about at ease, and then this is my last slide. So thank you very much.
Well, I hope you understand why I love Thérèse, because she is from talk to action. And I think this is a wonderful example of how you can actually put all these slides into real action and make support for young people. If you want to refer people in Rotterdam, they're just next door here. They're next door.
They're in this building.
In this building.
Rotterdam is this building.
Yeah, so they're very close by. So I hope that this has inspired you, that even if mental health is not your field of care, you are very often seeing young people with depressive or anxious thoughts, and you know now how to refer them. Thank you very much.